Hi, I'm Dr. Saeed, Acting Chairman of the Department of Psychiatry and Behavioral Medicine and Co-Director of the Anxiety and Mood Disorders Clinic at the University of Illinois College of Medicine at Peoria. With my colleagues, I'll be presenting a clinical update in obsessive compulsive disorder, a relatively common psychiatric condition. Long considered to be a rare disorder, new data have revealed that obsessive-compulsive disorder, in fact, is a common illness. An OCD patient may spend hours a day washing his or her hands while recognizing that there is no real reason to do so. Some OCD patients may check and recheck that a stove is turned off, that a door is locked, and so on. Some patients do not have rituals, but they endure endless hours of intrusive obsessive thoughts. In its severe forms, OCD may be so severe that patients are unable to work and, if untreated, disabled for life. There are now effective evidence-based treatments, including pharmacological agents and behavior therapy, that result in considerable improvement for the majority of these patients. Comorbidity of OCD with depressive disorders and other anxiety disorders is also fairly common and often complicates the diagnosis. Therefore, before beginning treatment, it is important for the clinician to understand the entire clinical picture. Although there is clear evidence in the literature about obsessive-compulsive disorder being quite prevalent and a cause of significant morbidity and functional impairment, this illness remains as one of the most neglected, underdiagnosed, and undertreated in the clinical practice. The purpose of this continuing education program is to educate the audience about this prevalent condition and familiarize them with the evidence-based diagnostic approach and treatment options for obsessive-compulsive disorder. As you can see, our hope from this program is to focus on the diagnostic approach using DSM-4 criteria to help identify the diagnoses that are commonly comorbid with obsessive-compulsive disorder. Third, to focus on the treatment, and that's where to talk about the drug therapy and behavior therapy. We have distinguished faculty here this morning to talk about these areas and cover them adequately. The next in this program, we have Dr. Donald Black, who would talk about the clinical features, comorbidity, and diagnosis of OCD.
The hallmark of obsessive-compulsive disorder is the presence of obsessions, and compulsions are more commonly both. Obsessions are repetitive, intrusive thoughts that are perceived as inappropriate and uncontrollable. Compulsions are repetitive behaviors performed in response to an obsession in order to reduce anxiety or to prevent some dreaded event. While the possible clinical presentations of OCD are diverse, the number of symptoms seen routinely in practice is limited and stereotyped. For example, OCD patients are typically concerned about contamination, harm coming to others, aggressive or sexual impulses, or counting. Compulsive rituals typically involve washing and checking, counting, ordering and arranging, or hoarding. The patient with OCD is made anxious by the obsessional thoughts. The anxiety is then typically relieved by performing the ritual. For example, fears of contamination are relieved by repetitive hand-washing rituals. In practice, most OCD patients will have many different obsessions and compulsions, but will be able to identify a primary or major obsession or compulsion, for example, hand-washing. OCD is diagnosed when obsessions and compulsions are severe enough to be time-consuming, cause marked distress, or lead to significant interference with social and occupational performance. Many symptoms of OCD are relatively nonspecific. Clinicians may recognize anxiety, worry, fear, anticipation, poor concentration, along with physical tension and mood changes. This may lead to a diagnosis of depression or some nonspecific anxiety disorder rather than OCD. In order to diagnose OCD, it is important to focus on the obsessions and compulsions that occur. Screening questions can aid in the diagnosis of OCD. Some examples: do you wash your hands over and over? Do you check things repeatedly? Do you have thoughts that distress or upset you that you cannot get rid of? When patients respond affirmatively, additional inquiries about the duration, scope, and severity of the symptom can be made. OCD generally coexists with other psychiatric disorders. The most common comorbid states are major depression, anxiety disorders such as panic disorder, generalized anxiety disorder, and the phobias and tic disorders. The connection with depression is of special significance since nearly 80% of OCD patients develop depression at some point during their lives. Motor tic disorders, including Tourette's, are also relatively common in OCD patients and should be looked for. Personality disorders, particularly those from the so-called anxious cluster, are also common. OCD patients are often described as shy, timid, unassertive, dependent, rigid, or even passive-aggressive. The accurate assessment of OCD begins with its recognition and the exclusion of other disorders that may be confused with OCD. For example, depression can cause obsessive-compulsive symptoms, but they tend to diminish as the depression lifts. Schizophrenia can cause bizarre thoughts and behaviors, but patients generally are out of touch with reality and attribute the thoughts to external sources, unlike the OCD patient. The patient with generalized anxiety disorder worries excessively, but generally about real-life problems which are viewed as appropriate, again, unlike the OCD patient. For a more thorough assessment, the Yale-Brown Obsessive-Compulsive Scale and Checklist may be used. The checklist allows the clinician to systematically assess all types of obsessions and compulsions with the patient. The 10-item scale assesses severity of obsessions and compulsions, yielding a score from 0 to 40. Typical outpatients with OCD score around 25. The scale may also be used to monitor improvement with treatment. Now, the DSM-4 classifies obsessive-compulsive disorder as an anxiety disorder alongside panic disorder, agoraphobia, post-traumatic stress disorder, and so on. Some investigators feel that OCD is sufficiently distinctive that it ought to stand alone. Nonetheless, DSM-4 defines obsessions as follows: A, recurrent and persistent thoughts which are experienced as intrusive and inappropriate, and which cause marked anxiety or distress. B, the thoughts, impulses, or images are not simply excessive worries about real-life problems. C, the person attempts to ignore or suppress such thoughts or impulses, or to neutralize them with some other thought or action. D, the person recognizes the obsessional thoughts, impulses, or images as the product of his or her own mind and are not imposed from without, as with thought insertion. The DSM-4 defines compulsions as follows: A, ritualistic behaviors, such as hand-washing or checking, or mental acts, for example, silent praying, that the person feels driven to perform in response to an obsession or according to rules that must be applied rigidly. B, the behavior or mental act is aimed at preventing or reducing distress or preventing some dreaded event or situation. However, the behaviors or acts either are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. The presence of comorbid conditions can complicate the diagnosis of obsessive-compulsive disorder, so certain general distinctions are helpful. For example, many of the disorders that are associated with obsessive-compulsive disorder are also characterized by intrusive thoughts, but few have ritualistic behaviors attached to them. Therefore, the presence of compulsions is highly suggestive of obsessive-compulsive disorder, while their absence makes obsessive-compulsive disorder much less likely. Irrational fear is a symptom that is shared by obsessive-compulsive disorder and many other anxiety disorders such as panic disorder, phobias, and generalized anxiety disorder. However, unlike obsessive-compulsive disorder, panic attacks are often accompanied by a subgroup of physical symptoms, including breathing difficulties, dizziness, fear of death, and are generally not triggered by specific stimuli. Differentiation of a specific phobia, that is, the persistent fear of a specific object or situation, from obsessive-compulsive disorder can also be based on patient response to the feared stimulus. Phobic patients will respond by avoiding the phobic stimulus, despite disruption of their lives and relationships. On the other hand, obsessive-compulsive disorder patients have a ritualizing response to the anxiety-provoking stimulus. The anxiety-inducing fears of patients with generalized anxiety disorder, while excessive, are derived from real-life situations such as loss of a job, and are thus realistic to those affected. In contrast, the fears of obsessive-compulsive disorder patients do not usually involve real-life situations and seem senseless to them. The boundaries between obsessive-compulsive disorder and major depression may be distinguished by focusing on the nature of the obsessional thoughts and the patient's perceptions of their meaning. At the root of the problem is the difficult distinction between pure obsessions and depressive ruminations. Depressive ruminations usually involve depressive themes such as guilt and low self-esteem that are not considered senseless or inappropriate by the depressed person. A differential diagnosis may be difficult in patients with obsessive-compulsive disorder who have somatic symptoms and patients with somatoform disorders, because both types of patients can demonstrate extreme preoccupation with physical symptoms. Some hypochondriacal patients who are fearful of developing life-threatening illnesses such as cancer have checking rituals that are very similar to the compulsions of obsessive-compulsive disorder patients. However, overall, patients with somatoform disorders tend to give greater importance to their symptoms, are less likely to resist them, consider them sensible and appropriate, and do not respond to symptoms in a ritualistic way. Despite its name, obsessive-compulsive personality disorder is not associated with true obsessions or compulsions. The clinical features of this disorder include a long-standing pattern of perfectionism, inflexibility, and the need for control, traits that are well-integrated parts of the patient's personality. Although these personality traits constrain professional and personal relationships, they are rarely recognized by the patient as problematic. Schizophrenia is usually more easily distinguished from obsessive-compulsive disorder, although magical thinking and ritualized behavior may be similar in the two disorders. Schizophrenia is associated with hallucinations, delusions, and markedly disorganized speech or behavior, which leads to severe social and/or occupational dysfunction. Compared with obsessive-compulsive disorder patients, schizophrenic patients have little or no insight into their disorder and generally share their thoughts with more conviction and less self-doubt. The explanations offered for their unusual thinking or behavior also tend to be much less plausible in schizophrenic patients than in obsessive-compulsive disorder patients.
Thank you for listening today to me as I talk about longitudinal course, disability, and related issues of nursing discipline. We'll talk about onset, early and late, and levels of disability, issues related to nursing discipline, the philosophy toward the patient and working with the patient, and a brief case study. In Course on Disability, the onset of OCD can be in childhood and adolescence as well as any time in the life cycle. A study on obsessive-compulsive disorder in children and adolescents examined predictors in childhood for long-term phenomenological course. The only factor that predicted a poor outcome, defined as the presence of OCD in adulthood, was severity of OCD in childhood. Age of onset did not predict the phenomenological course of OCD. Follow-up study of 23 Danish cases in the course of OCD in children and adolescents had results of approximately one-half of the children and adolescents retaining an OCD diagnosis at follow-up. One-third of these children had an episodic course of the illness, and two-thirds had chronic OCD. This short-term but intensive study supported theories of OCD as an illness with fluctuating severity. Previous findings that OCD seems to be chronic in approximately half of the cases were supported by this study. In a case of late onset, a 78-year-old woman with a history of depression who experienced sudden onset and rapid escalation of OCD following a domestic accident. Cognitive behavioral therapy was done in her home for 8 hours, and the Yale-Brown obsessive-compulsive self-rating scale was 35 before treatment and 12 post-treatment. In issues related to nursing discipline, OCD is called the disorder of doubt. The OCD patient is filled with shame and disgust, embarrassment and guilt. They are very good at hiding the symptoms, and it must be sought out by the clinician. Their lives are consumed by doubt and fear and ritual to avoid their perceived bad consequences. This is truly a therapeutic opportunity, which requires the therapist to walk with the patient, accommodating for each individual response while maintaining a forward progression toward response prevention. As opposed to other psychiatric disorders wherein the patient is unaware or has poor insight of their own pathologies, OCD patients are very aware. They require much sincere and respectful support. They feel constantly at war with themselves, as they know their thoughts are irrational, but they are compelled to repeat them. They often feel tortured. Their sense of self has been assaulted by OCD, and the clinician must do everything to realistically enhance the positive characteristics in the patient. Collaborating with the patient is essential to building that sense of self and esteem. This is truly one of the greatest opportunities for therapeutic use of self, to relay to the patient the therapist's firm belief and respect of the total patient. These patients require the utmost patience, for the obsession seems so obvious and irrational to the observer. One must always maintain composure with underlying respect for the great discomfort the OCD is causing the patient, and for the human being who suffers from this disorder. There's a wide spectrum of dysfunction, sometimes with total disability to do daily tasks, and the emotional suffering itself is crippling. And key points of therapy in exposure response prevention is to educate the patient as to how behavior therapy works and how to use it. An analogy of compulsions as addictions can be helpful. Doing the ritual decreases anxiety in the short term, just as occurs with drug use in addicts. However, in the long term, it perpetuates the problem. Performing a ritual can be compared to a fix. Response prevention can be compared with being drug-free. The therapist and the patient draw up the initial treatment plan. Collaborative effort is essential and gives the patient a sense of control. List symptoms that interfere most with a patient's lives. Guide and support. Be firm and consistent, but don't force. Patients need to learn to confront the fears themselves, and they need to tolerate their anxiety. Exposure must occur in areas that bring on the symptoms. Sometimes this can be done in the office, sometimes not. Many patients do well if the rationale is explained with being given homework assignments with families or friends in support. Modeling the assignment can sometimes help, but is not always necessary. Some examples of the assignments are touching the toilet seat or other items while avoiding the ritual of hand washing. Patients with primarily obsessive thoughts may use avoidance, so assignment could be to confront some of these areas. If the patient's ritual is to seek reassurance, family, with patient's permission, can agree to say, "We agreed not to reassure you," when the patient asks for reassurance. A common assignment used for trichotillomania is to glue all hairs pulled in a day on a 3x5 card and bring it to therapy appointments. Pure obsessional ruminators without rituals are more difficult to treat. Basic techniques include thought stopping and exposure. Thought stopping is when a patient is asked to bring on the obsession and then try to stop or block it by clapping hands, shouting, or using a physically aversive stimulus, for example, snapping a rubber band on the wrist. Exposure consists of deliberately ruminating on the obsession and elaborating on it for a given period of time each day. A variation is to write the obsession many times. Exposure and response prevention assignments are usually of increasing difficulty over time. Lengthy exposure and response prevention sessions are better than short ones. The patient is encouraged to remain in contact with the anxiety-provoking stimulus until anxiety dampens down or as long as practical. Then refrain from ritual as long as possible. If the patient can't completely stop, then agreement is reached on ways to delay, reduce, or even change the ritual. Stress to the patient that learning to tolerate the anxiety is an essential component of treatment. Reduction or avoidance of anxiety through ritual maintains the cycle. Perhaps my most memorable and enduring OCD patient was a 34-year-old divorced white female with severe OCD. She had extreme fears of contamination and severe rituals of hand washing and a total inability to take medication. She was seen every week by top specialists, yet it took all of the treatment team, including multiple inpatient stays, 2 years to finally get her to the point where she could tolerate taking medication, which would control her symptoms. It was worth it, and she's doing quite well. Thank you.
So far in this program, we have discussed the clinical features, diagnosis, and associated comorbid conditions of obsessive-compulsive disorder. Now let's talk about the treatment approaches to this illness. In this section, we will first talk about the pharmacological treatments, followed by behavioral treatments. What was previously thought to be a rare and difficult illness to treat appears to respond well to several pharmacological agents. Case reports of successful treatment of OCD have involved almost every antidepressant available. However, clomipramine, fluvoxamine, sertraline, fluoxetine, and paroxetine are the only medications that have demonstrated significant efficacy in double-blind, placebo-controlled, multi-center trials conducted in patients with OCD. The pharmacotherapy of OCD is based primarily on the use of serotonergic antidepressants. SSRIs and clomipramine share potent serotonin reuptake properties, and they have been referred to as serotonin transport inhibitors, STIs for short. These STIs have become the cornerstone of pharmacological treatment in patients with OCD, and their preferential efficacy in this disorder forms the basis for the serotonin hypothesis of OCD. The best and the most extensively studied anti-OCD agent available today is clomipramine, brand name anafranil, which is a tricyclic antidepressant with specific anti-OCD properties. Numerous positive open trials since the initial report of its efficacy were followed by at least 22 controlled trials in which clomipramine was either more effective than placebo or active comparator or equally effective. It's a potent serotonin reuptake inhibitor that also has anticholinergic, antihistaminergic, and anti-alpha adrenergic potency, as well as an active metabolite that's a potent norepinephrine reuptake inhibitor. Now, these neurotransmitter activities also account for the spectrum of the side effects that this agent tends to have. The optimum dose is unknown, but the majority of researchers believe that the dosage should be increased to 250 milligram a day if patients can tolerate the side effects. The main drawback to clomipramine is its substantial anticholinergic side effects. Sexual difficulties are common, and a small incidence of seizures occur at higher doses. Although most patients tolerate it well, these side effects may limit the use of clomipramine or impact a patient's compliance with the prescribed regimen. As with other TCAs, an overdose carries a substantial risk of death. The second group of classes used in OCD are the SSRIs, or selective serotonin reuptake inhibitors. Multi-center, placebo-controlled parallel design trials of fluoxetine, fluvoxamine, sertraline, and paroxetine have been completed and reported. Each of these controlled trials found the active compound significantly more effective than placebo. As with clomipramine, onset of improvement was delayed for many subjects, with significant differences only emerging between 2 and 6 weeks, and continuing to increase to at least 10 weeks. SSRIs have also been compared with clomipramine. Head-to-head comparison. A control study using a crossover design comparing clomipramine and fluoxetine in 11 OCD patients did not find a statistically significant difference in response over 10 weeks. A reanalysis of this study using a 25% improvement criterion found that 5 patients responded to clomipramine but not fluoxetine, 5 responded to both agents, and 1 responded to neither treatment. Clomipramine has also been compared with fluvoxamine in at least 3 controlled studies. Again, there were no significant differences in OCD symptom reduction or in response between the 2 agents. So, the head-to-head comparison of clomipramine and SSRIs have not shown any significantly superior activity on either of the agents. However, when side effects occur with SSRIs, they most often involve GI symptoms or activation complaints, such as patient reporting feeling edgy, feeling wired, tremor, insomnia, and so on and so forth. Inhibited orgasm is reported more frequently with all potent STIs, including both SSRIs and clomipramine, and this is when we compare them with other antidepressants. The results from meta-analyses of the multi-center control trials suggest that clomipramine may be associated with a relatively greater reduction in OCD symptoms when compared with SSRIs, and that no significant differences exist between the individuals' SSRIs. As you can see that this data is somewhat different from the head-to-head comparison. However, the indirect comparisons done in meta-analyses have their own limitations and must be viewed with caution. There are also many methodological issues in such a study that make firm conclusions difficult. Some of the other pharmacological agents that have been used in OCD, there have been some support in literature for use of agents like certain benzodiazepines, buspirone, monoamine oxidase inhibitors, and neuroleptics. The use of these medications is limited to clinical scenarios where the standard treatment has not been effective. These drugs should not be used in OCD without careful thought and special efforts to ensure informed consent because of the risk of tardive dyskinesia and EPS with antipsychotics, risk of physical dependency with benzodiazepines, and dangerous drug or drug-food interactions with MAOIs. Another thing to consider in treatment of OCD is the different augmentation strategies. The pro-serotonergic augmentation are logical in a disorder so clearly responsive to potent as serotonin reuptake inhibitors blockers. The rationale for their use is greatest when partial response has been obtained with a potent SSRI. There have been open trials, augmentations with lithium, tryptophan, phenfluramine, and buspirone on these lines. Neuroleptics are another medication class that has been used to augment partial response to serotonin reuptake blockers. Comorbid tic disorders or schizotypal personality predict a good response in controlled as well as open trials. Some of the other agents for which there is support in the form of case reports or anecdotes include carbamazepine, trazodone, and nortriptyline. The duration of pharmacotherapy, all reports of extended pharmacotherapy with potent SSRIs indicate maintenance of or increase in short-term gains for many months. OCD is a chronic illness, and patients will probably require medication indefinitely. It's generally felt that patients must continue to take the medication to maintain the gains achieved through downward titration to determine an optimum dose, which usually is the maximum benefit with minimum side effect dose, and this approach is considered appropriate. Few discontinuation studies are available, but patients seem to relapse rapidly whenever potent SRIs or SDIs are discontinued. So let's summarize the pharmacological treatment. First, we know from the controlled trials that clomipramine, anafranil, fluoxetine, Prozac, fluvoxamine, Luvox, paroxetine, Paxil, and sertraline, Zoloft, are all effective in controlling OCD symptoms. An adequate trial usually requires 8 to 10 weeks of relatively higher dosage of an anti-OCD agent, which for clomipramine is 150 to 250 milligram a day, for fluoxetine 60 to 80 milligram a day, for fluvoxamine 150 to 300 milligram a day, for paroxetine 40 to 60 milligram a day, and for sertraline 150 to 200 milligram a day. Another thing that we know from the data is that medication response is usually partial. Total symptom remission is rare. Clinical experience suggests that lack of response to one SSRI does not necessarily indicate non-response to another SSRI. Acute treatment duration is typically at least 9 to 12 months. Most patients will require long-term treatment with anti-OCD agent, and relapse is common after medication is discontinued. So this in summary is pharmacological treatment, evidence-based treatment. In the next section, Dr. Timothy Bruce will talk about the evidence-based treatment options, including behavioral treatments.
Hi, I'm Tim Bruce from the University of Illinois College of Medicine in Peoria. I'd like to talk to you about exposure and response prevention for OCD. The treatment technique of exposure and response prevention was drawn originally from research on classical and operant learning. Exposure can be traced to classical extinction. which is the principle that repeated exposure to feared stimulus in the absence of the feared response will decrease the feared response to that stimulus. Response prevention can be traced to negative reinforcement, which is the principle that suggests that an action that successfully lessens an aversive experience or neutralizes it is much more likely to be repeated. Today's models of exposure and response prevention reflect advances in learning theory and cognitive psychology that emphasize patients' appraisals of fear. From these models, obsessive appraisals tend to overestimate threat. For example, someone who fears contamination is overestimating the likelihood of this and overestimating the unmanageability of the situation. Compulsions reduce anxiety, but they prevent the patient from learning to appraise that threat more realistically, and so they serve kind of this negative reinforcement function. Therefore, treatment involves encountering objects of the threat while resisting compulsions, so a more realistic appraisal of the threat, more appropriate reactions can be established. To overview the treatment features of exposure and response prevention, it's a goal-directed, time-limited therapy. It usually can be done in less than 20 sessions. It's conducted individually and preferably with a coach, a significant other, particularly the family members. It involves exposure, gradually re-entering activities that elicit the obsessional fears, while preventing compulsive rituals. It can be done intensively, like with daily appointments, or more conventionally if the patient can be monitored in between with the weekly appointments. And it's typically individually tailored to the patient's fears and particular compulsions. The major treatment components to exposure and response prevention are depicted in the slide that you're seeing. They include education about the model, treatment rationale, coping strategies training, exposure to feared situations, response prevention, and efforts to consolidate this new approach to addressing fears and prevent relapse. I'd like to discuss each of these briefly, if I could. The education and treatment rationale is explained to the patient. During the educational portion of treatment, patients are helped to recognize the cognitive biases inherent in their sessional thinking. The effort's not to try to change those, but just to recognize those and set them up as hypotheses that can be tested and disputed. And most patients can do this. Some discussion is done of the role of avoidance in maintaining fears, and this provides the rationale for using exposure exercises as a means for testing and dispelling fears while learning a new approach to managing them other than through compulsive rituals. Coping strategies training teaches patients how to manage the anxiety and urges to ritualize that they're going to experience during exposure and response prevention procedures. These are also tailored to the individual, but can include relaxation training, breathing retraining, thought stopping to help stop the kind of train of obsessive thinking, coping self-statements, and sometimes even aversive techniques if patients prefer, snapping a rubber band on one's wrist and things like this to help help them regroup and cope are sometimes used. Of course, a major treatment component is exposure to the feared situations. This can be done imaginally or live, that is in vivo exposure, often begins with imaginal exposure and then graduates to in vivo exposure. It's often assisted by the therapist, preferably a coach is present. It's very helpful, as I mentioned, to have the family member involved so that the changes can be integrated into the family system and supported by them. Exposure is usually guided by a fear and avoidance hierarchy, which is constructed at the beginning of treatment. This slide shows you an excerpt of one of those hierarchies. It's constructed by assessing the different types of activities that elicit the obsessional fears, having the patient rate them on like a 0 to 100 or other Likert type scale, and then rank ordering those. Exposure then proceeds from the low fear to the high fear items. A list of 5 to 15 activities is typically useful and sufficient. Research on exposure has produced some guidelines and considerations for its use. Exposure is optimized when it's systematic and repeated, as opposed to just done infrequently, as a lot of patients do prior to coming to treatment. It should be done as frequently as possible without burdening the patient. It should be done in long durations, and with OCD, exposures are often a long duration. For example, a patient who fears contamination touches a contaminated object, the exposure is on. As long as they're prevented from engaging in the compulsion, the exposure continues and may for days, for an entire day or days. So it requires intensive monitoring the patients to help them kind of resist and engaging in the compulsion while this exposure proceeds and their anxiety lessens over time. Exposure should be done at a patient's pace, but with a firm supportiveness and encouragement to try to help them challenge their fears. And they should be corrective and educational. In other words, they should be valid tests of a patient's fears. They should be learning experiences rather than just entering the situation and leaving it. Response prevention refers to limiting or banning the compulsive actions during and after exposure. For example, for fears of contamination, a no-wash rule might be instituted for a day or days, or hygienic practices limited to just what's necessary. For checking compulsions, for example, they might be limited to just one time, and thought stopping may be used to counter mental rituals, such as counting. These kinds of response prevention practices can be done very strictly if patients prefer, almost like a cold turkey, let's just stop doing it, or they can be instituted gradually. For example, with a checking compulsion, maybe starting out doing it just 3 times, graduating to 2 and 1, that kind of thing. For the approximately 25% of OCD patients who only suffer from obsessions, response prevention obviously isn't necessary. Rather, exposure is continued and the focus is on helping them develop coping strategies for managing the obsessive thoughts that are going to be provoked by the exposure. Finally, as therapy continues, efforts are made to consolidate the new approach to the fears that the patient's developing. This typically involves continuing exposure and response prevention through the hierarchy, maybe extending it into areas beyond just the functional disability. The emphasis is on training a new approach, as I said, not necessarily exhausting every conceivable activity that can provoke obsessions. In this way, patients are better equipped to handle unexpected encounters and future encounters and maintain this gain, take it with them after acute therapy. There's also some education done about relapse prevention, how relapse occurs, methods to prevent it. This might include a review of high-risk situations that the patient and therapist can review and practice and plan for. It might also include booster sessions after acute treatment. Moving now to treatment outcome, the effective exposure and response prevention on OCD has been subject to extensive controlled studies by multiple investigative teams over the past 3 decades. As this slide depicts, just summarizing across controlled studies, the overall improvement rate for this type of treatment approach is in the 60 to 90% rate range. If we break this down then by different levels of end-state functioning, a conservative estimate is that approximately half of patients will be symptom-free or much improved by the end of acute treatment. Approximately 40% will be improved, and those proportions can vary from study to study, and about 10% will get no benefit from the treatment. One of the unique benefits of exposure and response prevention is that relapse rates after it, that are approximately 25%, are lower than those following discontinuation of other effective treatments such as pharmacotherapy. Those relapse rates are often in excess of 50%. Currently, more intensive relapse prevention programs are under study and they appear promising. They suggest that things like family support, stress management, booster sessions help patients maintain the acute treatment gains, prevent the relapse that's common in the maintenance of response to exposure and response prevention. From more neurochemical camps, there's some preliminary PET scan studies that have found decrements in activity in the orbital frontal cortex and caudate nucleus of patients successfully treated with exposure and response prevention, areas that are implicated in the perseveration of thought and behavior and the brain's ability to filter irrelevant information. There's also been some factors that can complicate the response to treatment, whether it's exposure and response prevention or other ones. These include comorbid conditions such as personality disorders, particularly schizotypal personality disorder, comorbid substance abuse, or significant depression. In addition, poor family support has predicted relapse following treatment as well. If we summarize the advantages and disadvantages briefly of exposure and response prevention, the advantages include a favorable acute treatment gain, favorable maintenance gain. The primary disadvantage of this treatment is that it's difficult and it takes time. So refusals and dropouts, non-compliance due to anxiety of approximately 25% are common. The other problem with this is that it's not readily available. It requires some specialized training, so there may not be access to this type of treatment in a lot of places. In terms of treatment selection, exposure and response prevention is considered an appropriate first-line intervention for OCD. The decision to add pharmacotherapy to it is made on a case-by-case basis. It involves consideration of a number of factors, including the severity and type of OCD, comorbidity, patient preference. Dr. Saeed will discuss some of these later. Some initial studies suggest that a combination of exposure and response prevention can be helpful in severe, complicated cases of OCD, although the long-term and other relative benefits of combined treatments are really unknown and are being investigated currently. But because of its help in maintaining gains after acute treatment, it's generally accepted that exposure and response prevention should be a part of any treatment plan. Unfortunately, recent surveys have found that less than 15% of patients presenting for treatment have exposure and response prevention in their treatment plan. So while OCD sufferers have medication and behavioral treatment options available to them, optimizing a treatment plan involves considering a number of factors, as I've mentioned. And now Dr. Saeed will discuss some of those considerations in treatment selection. Thank you very much.
So far we have talked about the pharmacological treatment and the behavioral treatment of OCD separately. Let's discuss the overall treatment selection. We know from the data that potent STIs and behavior therapy are the cornerstones of effective treatment of OCD. The efficacy of STIs is broadly comparable to that of exposure and response prevention. If both modalities are available, a patient may choose to begin with one or the other or the combined treatment. Many patients prefer to start with medication, hoping to lessen the intensity of obsessions, compulsions, and fears before beginning exposure and response prevention. Some will decide that the gains they achieved with medications are sufficient and decline behavior therapy. Pharmacotherapy has typically been the first-line treatment for OCD. Exposure therapy has gained more recognition over the past several years due to its promising acute treatment efficacy rates and lower relapse rates, as demonstrated by controlled clinical studies. Recent studies indicate that combined medication and behavioral treatment is a promising first-line intervention, particularly with patients suffering from severe anxiety or comorbid depression. Additional studies are warranted at this stage to further support these conclusions. The decision to use a combined treatment approach should consider initial use of pharmacotherapy alone with individuals who are severely depressed or highly anxious, possibly followed by a trial of behavior therapy after their depression or anxiety has decreased to a more tolerable level. We should also take into account that behavior therapy is not always available or accessible to the patients. And of course, patient preference for a first-line treatment approach should be taken into account before a decision is made about combined treatment. OCD tends to be commonly comorbid with other psychiatric disorders. These have included depression, anxiety disorders such as panic disorder, social phobia, and other specific phobias, eating disorders, schizophrenia, autism, and Tourette syndrome. Since comorbidity with other disorders is very high, these comorbid conditions should also be taken into account when planning treatment. The high degree of comorbidity in OCD patients increases the complexity of the differential diagnosis, which in turn increases the risk of misdiagnosis and treatment resistance, and affects the pharmacological management as well as the combined treatment. An important consideration in selecting an SRI or STI may also be the comorbid symptoms clusters. For example, if patients have considerable apathy, psychomotor retardation, or fatigue, an activating compound such as fluoxetine might be considered. In contrast, in patients with agitation or panic, one might consider a less activating agent. It is also important to be aware of the differences in cytochrome P450 enzyme system profiles of different STIs, especially when patients are on concomitant agents for psychiatric or general medical conditions. So, concluding this program, OCD is a highly prevalent and disabling anxiety disorder that often does not find its way to the effective pharmacological and behavioral treatments available today. It is commonly complicated by comorbid conditions. Recognizing and thoughtfully treating this disorder and its comorbid conditions can help these patients to appreciative improvements. Although complete remission is unusual, patients complying with both therapies, that is pharmacological and behavior therapies, have a high probability of significant gains. Both pharmacological treatments with potent STIs and behavior therapy in the form of exposure and response prevention have demonstrated treatment efficacy and are considered to be evidence-based treatments for OCD. The combined use of these treatments gaining favor in more recent clinical practice is receiving initial empirical support as an appropriate first-line intervention. Therefore, thorough evaluation is necessary to match the patient with appropriate treatment. We hope you found this program to be informative and helpful. Thank you for your attention.